Hi, my name is Aaron Brenner, and I'm an internal medicine PGY2 at the University of Kentucky. I will be presenting research on outcomes and indications of palliative care in decompensated cirrhosis. So decompensated cirrhosis leads to pretty poor health-related quality of life. Patients have a symptom burden similar to those with advanced malignancies, and Kentucky had the highest increase in mortality between 1999 and 2016 in patients with decompensated cirrhosis. Palliative care is end-of-life care, spiritual issues, symptom management, psychological issues, social and cultural issues, and advanced care planning. Our objective was to evaluate the why, the indications, and the outcomes of palliative care consults in patients with decompensated cirrhosis. We examined patients at University of Kentucky in a retrospective observational cohort study, only adults with decompensated cirrhosis and a palliative care consult, and excluded any patients on surgical services. We found that most of our patients had cirrhosis secondary to NASH or hepatitis C. Our average age was 61, MELD sodium 21.4, and days to consult 4.9. Most of these patients had palliative care consults for advanced care planning, physical symptoms, and psychosocial issues, and also cultural issues. The majority of these hospitalizations, or about 1/3, ended in patient passing away in the hospital, while about 40% ended in some kind of transition to hospice, either home, skilled nursing facility, or inpatient. So the most common reason for palliative care consult in our patients with decompensated cirrhosis was advanced care planning. So things like code status and the conversation around that, and then also palliative care was addressing psychosocial issues or needs and physical symptom needs in these patients. Our average MELD sodium of 21 suggests that these patients had a pretty advanced cirrhosis, and reinforcing that was that a third of these hospitalizations ended in death, along with 43% of the patients receiving some kind of transition to hospice care. So palliative care can contribute to many different aspects of patient care other than end-of-life care. They can help in advanced care planning, they can help control symptoms, they can especially help address the psychosocial battles that we may not see directly as a healthcare team. The advanced or the high MELD sodium and high percentage of patients going to hospice suggests that these consults were actually fairly delayed in disease and hospitalization courses. So further studies need to be used to address how do we find triggers for palliative care consults in this cohort of patients who are very sick to begin with. Thank you very much.